Bismillahirrahmanirrahim. Thank you very much. But before I go on to my talk, I think there's a very important concept on this peripheral interventions that I would like to clarify. We've got some juniors sitting at the back as well. Dr. Masood is sitting here. So I was listening to his talk in very early days when I was thinking of starting peripheral interventions. And the concept that I learned from him is very important for the juniors also to learn. So जब आप किसी की भी पेरिफेरल आर्टीरियल डिजीज़ है और अगर पेशेंट की आप देखें यहाँ पे एम्पुटेशन करते हैं, जिस लेवल से आर्टरी बंद है जब तक वहाँ से एम्पुटेशन नहीं होगी तो जो ज़ख्म बन रहा है वो भी ठीक नहीं होना. सो या तो आप आर्टरी को खोल के उस लेवल तक ले जाएं, जितना नीचे आप ले जाएंगे वहाँ पे जब आप एम्पुटेशन करेंगे तो उसमें ब्लड पहुँचेगा तो ज़ख्म ने ठीक होना है. सो लेवल ऑफ एम्पुटेशन को आप नीचे लेके जाते जाते हैं जितना आप एंजियोप्लास्टी करके फ्लो को बहाल करते जाएंगे. सो ये बड़ा इंपॉर्टेंट है कि डायरेक्ट एम्पुटेशन पे जंप ना किया जाए एंड फ्लो को जितना नीचे तक बहाल कर सकते हैं उसको इस्टेब्लिश किया जाए. सो सिंस डॉक्टर मसूद इज सिटिंग हियर, सो थैंक यू वेरी मच सर. यू ऑलवेज एनलाइटेंड अस विद योर knowledge and experience. So
sorry Dr. Asim, sorry just
sir,
what is the cutting line, the thing you are saying now,
sir,
between the amputation and between going for your procedure before the amputation? What is the bottom last line,
sir,
where you draw the line?
there is no last line as such. किसी की अगर टोज भी खाली गैंग्रीन हुआ हुआ है और आप अगर उसका फ्लो इस्टेब्लिश करते हैं, कोलैटरल्स पे चल रहा है, जैसा भी आप जितना उसका फ्लो इस्टेब्लिश कर देंगे तो जितना लिमिटेड गैंग्रीन था आपका गैंग्रीन उधर ही लिमिट हो जाएगा. ज़्यादा से ज़्यादा वो हो सकता है ऑटो एम्पुटेट उतना हो जाए या उसको एम्पुटेट करना पड़े, लेकिन वो जख्म तभी ठीक होगा अगर उस पॉइंट तक फ्लो इस्टेब्लिश है.
You mean to say that every patient who may be going for amputation should have this procedure first?
Should have imaging done टू सी के उसके अंदर क्या चीज़ की जा सकती है. क्या एंजियोप्लास्टी के जरिए हम कर सकते हैं फ्लो इस्टेब्लिश या वैस्कुलर सर्जन कर सकता है ग्राफ्टिंग. अगर दोनों चीज़ें नहीं हो सकती तो फिर किस लेवल पे आर्टरी बंद है जिस लेवल से फिर आपको एम्पुटेट करना पड़ेगा. अगर आर्टरी एसएफए के लेवल पे अबव नहीं बंद है और एक सर्जन पेशेंट का पैर एम्पुटेट कर देता है तो वो पैर का जख्म तो ठीक नहीं होगा, उधर फ्लो नहीं पहुंच रहा है. आर्टरी तो बंद है एसएफए अबव नी लेवल के ऊपर, या तो फिर वो अबव नी लेवल से एम्पुटेट करेगा तो फिर ही जख्म ठीक होगा. एम आई राइट सर मसूद?
Gangrene starts distally, so if you mistakenly amputate the distal part, you have to amputate again after a few weeks, bit more proximal. It's called Gandari amputation. So you avoid Gandari amputation, as he says. First of all, try to see where the lesion is. If the lesion is proximal, go for it. Otherwise, it will never heal. Never heal.
So these patients always need at least a CT angiogram.
Yes. So imaging assessment is important.
So coming back to my topic, since my time is running, I'll try to be as quick as possible. So stroke is a leading cause of death and disability worldwide. Globally, every fourth person aged over 25 years will suffer a stroke in their lifetime. 2/3 of stroke patients die or have moderate to severe disability, and only 1/3 are lucky enough to live with minor disability or recover fully. So the objective given to me today is to explore the historical evolution and how AI is revolutionizing stroke care. So in the 5th century, Hippocrates, the father of medicine, was the first to recognize stroke. And then it was 1658 when Dr. Johann Jacobs of Switzerland, he distinguished first time between ischemic and hemorrhagic strokes based on postmortem examination. 1807, Dr. Amos performed the first carotid artery surgery in USA to prevent stroke. So to prevent stroke, it was 1807 when they were working on it. Therapy of stroke is now actually coming in. So there is a big gap in between. Now, 1927, Antonio Egas used X-ray technology to produce the first image of cerebral arteries in a living person. And then 1970s, everything started changing with CT scan technology coming in. So the first revolution in stroke treatment came in 1995 when IV alteplase got US FDA approval for use in stroke. But we do know that with thrombolytics, there is time constraint. There are so many contraindications to thrombolysis, and the most important concept that we must understand is that these thrombolytics in stroke are effective more in the distal and small vessels of the brain. But if you got a large artery of the brain blocked, then the TPA is not that effective as a sole treatment. So if you look here at the ICA, if the clot is there, the effectiveness of IV TPA alone would be only 4 to 8%. So that means we need to do something more, and this was realized very early on. So this was 2000 when this case report was published. People were trying to remove clots from the brain, so they used a coronary microcatheter, a micro snare to remove a clot, which they successfully did and established flow. And since then they've been trying. So in 2004 came the Mercy device, wasn't that very successful. So then came Solitaire AB. Now this stent was actually meant for stent assisted coiling of cerebral aneurysms. But then they realized that this could remove clot as well. And then endovascular treatment started evolving. Mercy, Penumbra, stent for stroke, and now the current generation is the stent retrievers. 2015 was a game changer. This was the second revolution in stroke treatment with all of these trials coming in. And then mechanical thrombectomy for large vessel occlusion got a class 1A recommendation. So this was within the first 6 hours. But then, based on DAWN and DIFFUSE 3 trials, the time window for mechanical thrombectomy got extended from 6 to 24 hours. Now what's important? Time is brain. If we can reopen a blocked brain artery within 2 hours, recovery rate is 90%. The West really realizes the importance. So what they're doing now is, they are now installing mobile CT scanners in these ambulances. So once they receive a call from home that the patient has collapsed or symptoms given from the family are matching that of a stroke patient, they would send one of these ambulances to the house, so that on the way they will get a CT scan done, and they will send that CT scan to the hospital, and they will guide them where this patient needs to be taken, either neurosurgery or a center for mechanical thrombectomy. Now, artificial intelligence is very quickly coming in and changing the whole landscape. Image analysis, clinical decision support, workflow optimization, prognostication, and outcome prediction, it's playing its role in all of these aspects. Now, many AI applications are there. What they are doing now is, this application within 2 minutes gives us the complete analysis of the stroke patient. It analyzes the plain CT brain, tells us if there is a bleed or not. If it is ischemic, it immediately analyzes the CT angiogram, exactly localizes where the clot is and which artery is blocked. It will show you. It then immediately analyzes the CT perfusion scan and tells us exactly how much brain is dead, how much brain is salvageable. At the end, it clearly writes down this patient is a candidate for mechanical thrombectomy, or it will say this patient is not a candidate for mechanical thrombectomy. And these images that you see here and this decision comes on our mobiles or on the email addresses of the whole on-call team that for that day. They will all receive these messages, and everything is done within 2 minutes by AI. So you get a good support with this. So RIC and NICVD both have these AI applications available to us now. Then many AI applications are there. Methinks, Wiz AI, Rapid AI, Sina. Methinks is now getting more advanced. What they are now doing is, instead of doing a CT angiogram, the AI is going to tell us based on a plain non-contrast CT, it's going to tell us that this ischemic stroke has a large vessel occlusion or it does not have a large vessel occlusion. So again, this is AI, and they are about to come out with it. Robots are being used in different therapeutics, so it's also coming into neuroendovascular. So the issue in neuroendovascular is that we have a lot of tortuosities in the cerebral circulation. So the routine wires that we use, the robotic arm when tried had a difficulty taking those wires up. So now they are coming up with these magnetic wires. So they have a magnetic tip, and what they do is, the robot is guiding these wires in. It's going to do the whole intervention with, of course, controls with the operator. But then at the head end of the patient, this magnetic arm is there. And this magnetic arm you can easily move, change, and this is going to guide the wire tip to go in which direction and take the bend in which direction. So with this, they are solving this problem of the cerebral tortuosities. And now this is my last slide, and this is something very interesting and will change the whole landscape of stroke intervention if it comes into play. So histotripsy is already being used for treating cancer patients. What it does is you have ultrasound waves that create micro bubbles within the clot, and as they expand and collapse, they mechanically break down the tissue or the clot wherever it is used. So they are trying this now on stroke. So the way it works is that, sorry, let me just play this video for you. ये वीडियो प्ले कर सकते हैं जी, उधर से आप कर सकते हैं, इसके ऊपर प्ले कर दें अगर सिर्फ, चलें, thank you very much. So you see this machine coming forward, so it's a mobile machine like an ultrasound. So patient has to be intubated under general anesthesia so that it does not move the head position. So this machine comes on, patient's head comes in between, and it will start doing a transcranial Doppler with the help of AI. So AI is going to start this transcranial Doppler. It's going to detect through transcranial Doppler where exactly the clot is sitting, which artery is blocked, and once it detects that the large vessel is occluded, then the transcranial Doppler will stop emitting the Doppler waves, and instead it will start doing histotripsy. What histotripsy will do is it will hit the clot, and the clot is going to break down and melt away. And in order to prevent the clot from distal embolization, it is going to hit from both sides. So from left and right, one side is going to hit the lower side of the clot, the other side is going to hit the upper side of the clot, and the clot in between is going to disintegrate and just it's going to move away. And this will really change the way stroke is being treated, because currently you don't have neurointerventionists. Even in developed world, you lack them. But once this machine is available, it will be available all over the world in every center, and stroke can easily be treated. But currently it's been successfully tested in the 3D flow models, and nowadays it's undergoing animal trials in Gates Vascular Institute with Dr. Adnan and his team. They are doing the animal trials on it. But if this technology had, I think this will be a giant leap in stroke treatment. So in conclusion, stroke care has evolved from sportive therapy to time critical interventions. Mechanical thrombectomy has revolutionized outcomes for LVO strokes. AI is transforming stroke care through rapid diagnostics and improved workflows to therapeutic interventions. Thank you very much.